Okay, so thanks very much. So colleagues, this afternoon we're going to have a very fruitful discussion, I think, and really the theme of this discussion is around what strategy would best suit South Africa. And as most of you know, we're in the really lovely period of RSV prevention. We've got two very effective strategies that have come on. This has been adopted by a number of high-income countries, and South Africa is on the verge of moving towards this as well, probably as a leading African country in this, and we're really excited about that. So today what we're going to do is we're going to start off with a very short presentation, which I'll give on just recapping some of the burden aspects as well as the clinical presentation. And then we're going to go to a presentation on the global preventative strategies, what is some of the efficacy and effectiveness data that's come through so far from mostly high-income countries. And then we're going to go to our panel. So I'm just going to mention who this panel is. We've got Professor Prakash, Jeena, who is from the University of KwaZulu-Natal, but importantly, Prakash is also the chair of the EDL committee or EML committee. And it's very important to get the perspective of what that committee thinks about these preventative strategies. And then we've got Professor Heather Zhao, who's from the University of Cape Town, and she's been chair of the RSV working group for WHO for a period of time now, and has been instrumental in moving this field forward from a global point of view. Then we've got Professor Shabir Madhi, who is on the SAGE, which is the Strategic Advisory Group of Experts for vaccination, and also by WHO, and we'll hear some of the insights as to what's happening from a WHO point of view. Then we've got Professor Rudzani Muloiwa, who's from the University of Cape Town, and importantly, he is on the NITAG and also the RITAG for Africa, so we'll hear from him as well. And then finally, we've got Professor Omolemo Kitchin, who's from the Pediatric Management Group and also a pediatric pulmonologist in private practice, and we'll be hearing from Omolemo as well. So we're going to start now with a very brief presentation. We'll then move on to Heather with the second presentation. Both these presentations are fairly brief, just to set the scene, and then we're going to move on to our panel discussion. So firstly, I'd like to say that SAPA as a South African Pediatric Association has been at the forefront of these discussions in terms of RSV prevention, and we're trying to engage the pediatric community with this. For starters, we published this article late 2024 that really talks about these preventative strategies. It was published in the South African Medical Journal. If you do get some time, please go through this paper, which really gives some of the backdrop and some of the data around efficacy. We then have this webinar, which we're doing today, and I must invite you to the SAPA conference, which is going to happen on the 5th of September in the Eastern Cape, and where we'll also be having a session set aside to talk about RSV. And really the themes for all these is really about what works best in South Africa. As people know, we've got the large state-funded public sector and we've got a smaller private sector, but yet both these sectors are important components, and both these sectors need to have some sort of strategy. If it's the same strategy, we'll hear from our panelists later on. I also want to draw your attention to some of the resources that you may want to use as pediatricians, as registrars, as medical officers in pediatrics. The PATH slides are available for people to access, and today I'll use some of these PATH slides in my presentation just to show what they look like. And these are a set of slides that have 6 topics, and they go through some of the preventative and burden of disease in terms of RSV, and they're open for people to use these PATH slides. And then if you see the link at the bottom, this is the WHO RSV Roadshow that's been happening. And from the right-hand side, you can see the program for this year. We've now going to the 13th of February and then the 5th of March sessions that will be available. These are online sessions, but the recordings are available through this website. So the outline of the talk, I'm going to talk about the burden of disease and clinical presentation, and then we'll hear from Heather. So in terms of global burden of disease, we know that RSV contributes 1/3 to all the causes of pneumonia, and you can see that on the pie chart on the top left. But more importantly, 33 million acute respiratory infections occur annually from RSV, with 3 million hospitalizations and approximately 120,000 deaths. 99% of these deaths occur in LMIC settings, including South Africa, And a large proportion of children require intensive care facilities. But importantly to mention that there is a large proportion of mortality that's happening outside the hospital when it comes to RSV, and this is unnoticed or unrecorded mortalities for most LMIC settings, and a younger age group that presents with RSV in this outpatient setting. And as you know, apnea is a presentation that can occur in the very young babies. But importantly to know that there's an increased risk of obstructive airways disease, including asthma in children who had RSV LRTI in infancy. And the pictures of the right is just really to show what's probably going to happen in the next few months in all our hospitals. We're going to see this increased number of admissions for RSV-associated illness. If we turn to the PERCH study, which was undertaken in 2012 to 2014 in 7 countries, when you look at the top 10 causes of severe pneumonia, RSV is the commonest cause. 31% of all pneumonia infections are from RSV infection across a number of countries in both Africa and Asia. And this just shows the proportional distribution to the next common pathogens. And as you can see, by far, RSV is the commonest. If you look at data from the ANISA study, this was a study looking at neonatal infections, and you can see that RSV also contributes to acute infections or community-acquired infections in neonates in South Asia, and 6.5% of these children were admitted with RSV infection. And then coming to the CHEMS study is the Child Mortality and Child Health and Mortality Prevention Program, and this is undertaken in 7 countries at the moment. And here we're looking at cause of death in children using minimally invasive tissue sampling. And by far, lower respiratory tract infection is the commonest reason why children die across these Africa and Asian settings as per the CHEMS study. And as you can look on the right-hand side, the circular distribution of RSV is not an unnoticeable cause of death, both as underlying and immediate causes of death. So we know RSV affects the lungs and the breathing passages, and this is no new news to clinicians on this call. And importantly, you have upper respiratory tract infections, and you can have lower respiratory tract infections from RSV. But we're really concerned about what happens when it gets to the lower respiratory tract. We have children presenting with bronchiolitis or children presenting with pneumonia. And both these presentations can have severe presentations which require hospitalization in intensive care facilities. This is just a figurative representation of what an inflamed bronchiole looks like. And severe disease, as I said, is a reality. Up to 20% of young children will experience apnea, and 85% will experience fast breathing. So the important point then to drive home is that how do we treat RSV? At the moment, there is no treatment available for RSV. It's largely supportive care, avoiding unnecessary medications like steroids and antibiotics unless indicated. I'm not talking about the steroids now, I'm talking about the antibiotics, and maintaining hydration and support where needed for the child. But we don't have any treatment strategy, and therefore the focus is then on prevention. So one of the ways that we've been preventing RSV up to now is by using the monoclonal antibody palivizumab. So what are monoclonal antibodies? They are antibodies manufactured in the laboratory to neutralize a pathogen. And how they work is they mimic the natural antibody that immune systems produce, and therefore preventing the attachment of harmful pathogens and helping to kill them. And palivizumab is what's been available to us as clinicians. If you look at the effectiveness data for palivizumab, it's 51%, but this is higher in high-risk groups, up to 80% effectiveness. But we do know that one of the drawbacks of palivizumab is the monthly dosing throughout. So it starts before the RSV season and then throughout the RSV season. And this is the current price for a 100 milligram vial. We're looking at about 6,500 Rand, and you'll need, depending on the weight of the child, I've just shown you the dosing per weight category. You'll need so many mils of fluid. And currently, the American Academy of Pediatrics has recommended palivizumab for high-risk infants under 12 months age. And these are really children who are severely premature, extreme premature, and less than 29 weeks, those with congenital heart disease, hemodynamically significant lesions, and those with chronic lung disease of prematurity. So that's the first strategy that has been available to us, which is a monoclonal antibody. And what we're going to hear from Heather is the newer monoclonal antibodies, and that's those ones that have come through to the market, which is Nasivimab, and we'll hear a bit more in detail about that. The second strategy is maternal immunization, and this is simply put, it's giving a vaccine to a pregnant woman to increase the number of antibodies that she has. She develops IgG antibodies, and these antibodies are then transferred to the baby via the placenta to increase the placental antibody levels in the baby, which are maternally derived, obviously, and then protecting the baby in the first few months of life from infection from RSV. So these are really the two strategies that I'm going to hand over to Heather. And just to say that if maternal immunization is a strategy to be adopted, it will be added to the current maternal immunizations that are available. For example, the recommendation by CDC, EMA, and WHO for influenza vaccine, COVID-19 vaccine, and the pertussis vaccine in South Africa. We've recently started the Tdap, which includes the pertussis. And if we were going to have RSV vaccine, then obviously that would also be entering an immunization schedule for pregnant women. So that's really the point that I'm going to stop. So I'm going to stop sharing, and then I'm going to immediately hand over to Heather. We're not going to take questions at this point in time. If there are questions, you can put it through on the chats, and Madhi will be monitoring that. Heather, I'm going to hand over to you for your presentation. Please go ahead.
Thanks so much, Ziyaad. I hope you can hear me and see the slides.
Yes, we can. Go ahead.
Okay, great. Fantastic. Thank you so much. Thanks to SAPA for asking me to speak to this, and also for this webinar, which I think is very timely, preceding the RSV season in South Africa, and to Ziyaad for setting the stage so well. And as you've heard, I'm going to talk about the two strategies which we currently have globally: a maternal vaccination or along the long-acting monoclonal antibodies. And just to highlight that the advances in these strategies have been made possible by research that stabilized the RSV virus in its pre-fusion state, shown here. You can see it's very different in a pre-fusion to a post-fusion state, and that these monoclonal antibodies and the maternal vaccine is directed towards a pre-fusion form of RSV, which is much more immunogenic. So let's just talk about maternal immunization first. This is a short presentation, so I think I've tried to focus on the key studies and the key results. The pivotal trial was the phase 3 trial of called Matisse, a pre-F RSV vaccine, double-blind, placebo-controlled trial given to pregnant women between in their second or third trimester, and the primary endpoints were medically attended severe RSV in infants or medically attended lesser severe illness, so RSV LRTI in infants, also through 90 and 180 days. And here you see the efficacy through 90 days and through 180 days, and you can see that the efficacy for severe RSV was 82% at 90 days and 70% at 180 days, and the efficacy for less severe disease was around 58% at 90 days and 50% through 180 days. And importantly, as you had highlighted, we know, and as all of you who care for these babies know, the highest risk is in the first 6 months of life for severe disease. And so this is a critical period in which babies were protected. The other important thing about this is that you can see here, and this is the Kaplan-Meier of the final analysis for severe RSV LRTI, you see protection from day 1 of life. So if you look in the first 30 days of life, you see already there's a big imbalance in the number of RSV cases between infants born to mothers who received vaccination versus those whose mothers received placebo. So that's really important, protection from day 1 and sustained protection through 180 days. And similarly, for less severe disease, medically attended, the same pattern, protection from birth and ongoing protection through 6 months of age. Now, there's quite a lot that has been written and spoken about in terms of birth outcomes. In general, birth outcomes were comparable between infants born to mothers who were who received the RSV vaccine versus those who received placebo, but there was an imbalance in preterm births, which I've highlighted here. You see 5.7% in infants whose mothers were vaccinated versus 4.7% in those who received placebo. And you see that this is also evident in the difference in low birth weight, slightly less in terms of difference, but there is this imbalance, which was not statistically significant. And if we try and unpack more details about these preterm births, this is a diagram of the timing of birth in relation to here in this shaded areas when mothers were immunized. You see between 24 and 36 weeks of gestational age. That was the indication for vaccination. And here in gray and blue, you see when the infants were born. And I think what is very striking is the majority of infants, in fact, were born full term from 38 weeks onwards. And if you look at the preterm births, and the gray is those whose mothers received placebo, and the blue is those who received a vaccine, you will see that in fact most of the preterm births are late preterm births, around 36, 37 weeks, small group in the 33 weeks or early preterm birth, and you can see that the numbers overall of early preterm birth are very small, with a mean of approximately 57 days from the time of vaccination to delivery, and no association between the timing of vaccination and preterm birth. Now, where did these preterm births occur? And here are the countries which had 5 or more preterm births. And you see South Africa at the bottom, in fact, was the only country in which a significant imbalance occurred. 39 preterm births in mothers who were vaccinated versus 19 in those who received placebo. And Argentina, there's a suggestion that sort of pattern is also occurring, but you can see overall the relative risk is not significant. And if we look at the impact of these preterm births, you can see here, and this is deaths, that amongst infants who were born preterm here, there was no association with an increased risk of death. One death in a preterm baby born to a mother who was vaccinated, and two deaths in a preterm baby born to mothers who received placebo. So obviously these numbers are very small, but if anything, the risk of death is lower in amongst infants whose mothers were vaccinated. Just to say that in South Africa, a lot of work has gone into analyzing this data. Multiple regulators have looked at this. They've been modeling studies, and WHO SAGE considered this data very, very carefully and concluded that the benefits of vaccination outweigh the potential risks. And in South Africa, that pattern of preterm births seem to be related to the COVID, Omicron, and Delta waves. And although no biological explanation has definitively been provided for the imbalance. So that led WHO SAGE to recommend last year that all countries introduce passive immunization to prevent severe RSV disease in infants. And for the maternal vaccine, the recommendation was for a single dose in the 3rd trimester of pregnancy. Usually that's 28 weeks of gestation, but in some settings it's 27 weeks. And in fact, SAGE did not recommend any upper gestational age limit for vaccination, except for active labor, and also confirmed that this vaccine can be given concomitantly with other vaccines in pregnancy during the 3rd trimester. And as Ziyaad said, many countries have approved use of the vaccine, and you see it's striking that these are largely high-income countries. This is a little bit outdated. I think this was in November, where there were over 50 countries. We've heard that SAPRA recently approved in South Africa, so we can add South Africa to the map, which is great. And these countries have differed in their recommendation for at what gestational age vaccine should be given. So you can see that some countries recommended the full indication for which Matisse was done, 24 to 36 weeks. Some countries have a more restricted recommendation, 28 to 36 weeks, which is more consistent with the SAGE recommendation, and others had an even more conservative recommendation, 32 to 36 weeks, based on the imbalance in preterm births. And most of these recommendations occurred before SAGE made their recommendation. SAPRA, I understand, has made a recommendation in the 28 to 36 week thing. And we can talk about this in the panel, but some countries have recommended year-round administration, and some countries have recommended seasonal administration. Argentina, I just want to mention, amazing program. They did a seasonal maternal vaccination program from March to August of last year, and over 140,000 pregnant women vaccinated. Amazing coverage for a maternal vaccination of 60% coverage, a good acceptability of the strategy. And these were the top line results that were announced. Very effective for preventing hospitalized RSV LRTI in infants under 3 months of age, around 73%, 68% in infants under 6 months of age, severe hospitalized prevention in infants up to 6 months of age, around 74%, very consistent with the Matisse data. And overall, there were only 3 RSV-associated deaths, all of which were in unvaccinated mothers. This was a test negative case control design. There's also a year-round program in England, different to Argentina, in that it's year-round. Again, this is a little bit outdated, but they have a slightly different indication. It's 28 to 36 weeks. Argentina is the more restricted indication, 32 weeks and above, and also a large number of women vaccinated. And we look to see the data on that as it emerges. To quickly speak about the long-acting monoclonal antibody, Ziyaad already mentioned palivizumab, and we know the limitations of that and the lack of access for most children. And we know also that most hospitalization for RSV occurs in normal, healthy, full-term infants, although, of course, there are a group of infants who are at high risk for more severe disease, such as preterms and congenital heart disease and those with chronic lung disease. And there are now 2 long-acting monoclonals, Omolemo, which has been licensed since 2023 and is now recommended by SAGE and WHO, and clesrovimab, which has had positive phase 2b and 3 results, is in late phase evaluation, and is actually at the, I think, the FDA and the EMA for approval. And either of these are given as a single dose at birth, or prior to or during the first RSV season, and they can also be used in a second RSV season in high-risk children. So again, the pivotal studies for nirsevimab, really 2 pivotal studies. The first study done in preterm infants, 29 to 35 weeks gestation, and the second study done in term and late preterm infants older than 35 weeks of gestation. The first study used a 50 milligram dose only. It was then realized that infants over 5 kilograms require a dose of 100 milligrams, and the second study was then used a 50 milligram and 100 milligram dose, depending on the weight of the baby at the time. There are other studies of immunocompromised or severe infants at risk of severe RSV disease, and here the efficacy is extrapolated through the PK data. So just to summarize the pooled data from the preterm and full-term results in infants in whom the correct dose was used, either 50 milligrams in those under 5 kilograms or 100 milligrams in those above, you see efficacy, very high efficacy for severe hospitalized RSV, around 79%, 80% for just hospitalized, and also similar, around 79% for medically attended LRTI. In addition, and this is another public health benefit that we need to be aware of, there was an impact on reduction in hospitalization for all-cause LRTI for medically attended all-cause LRTI, fewer outpatient visits, and of course, reduction that translates into reduction in antibiotic prescribing. And this is a bigger public health benefit than just prevention of RSV. The product was very safe. There's a pragmatic clinical trial of over 8,000 infants in 3 European countries that shows similar efficacy for RSV hospitalization and very high efficacy, also approaching 60% for all-cause LRTI hospitalization. So very high efficacy. This is the real-world trial, Harmony, which infants were randomized either to receive nirsevimab or usual care. And you see 83% efficacy there for hospitalization and 75% efficacy for very severe disease. And this effect was consistent across ages, across weights, across birth, gestational age at birth, across sex, and whether the long-acting monoclonal nirsevimab was given either during the RSV season or before. And the results consistently favor nirsevimab as being highly effective. And we now have a lot of effectiveness data, again, mainly from high-income countries, showing reduction in RSV hospitalization, reduction in RSV ICU admissions, reduction in RSV and medically attended lower respiratory tract infection. And you can see in the US, in Spain, in Brussels, France, etc., very high efficacy data that approximates, that really mirrors the efficacy from the randomized controlled trials. And this is really very reassuring. And I just want to highlight the results from Galicia, Spain, where again, a seasonal campaign was done for nirsevimab, all infants born prior to or during the season, as well as high-risk infants entering their second season. They got very, very high coverage. And you see these remarkable reductions in severe RSV, lower respiratory tract infection requiring oxygen, hospitalization, or again, the effect on all-cause LRTI, all-cause hospitalization. And if you speak to the pediatricians and the doctors here, they will tell you their wards were empty. So this is really, really very reassuring, very incredible effectiveness data. Now, I just quickly want to show you some data from clesrovimab, which is the second monoclonal, long-acting monoclonal that is waiting for approval. These are the results from the phase 2b/3 clinical study, and they just summarized here. The primary endpoint was through 5 months, 150 days, but I'm also showing you the data through 6 months. And you can see, depending on the outcome, the efficacy gets higher and higher. So if you look at the most severe outcomes, like severe LRTI or hospitalization, or 2 indicators of severity, you see the protection is, the efficacy is above 80%, approaching 92% for severe disease. And for acute respiratory infection, which includes upper respiratory tract infection due to RSV, you see around a 50% efficacy. And this is expected, that the more severe the disease, the more effective the protection is. And so importantly, and clesrovimab is slightly different. It's a single dose of 105 milligrams. The dose doesn't vary by weight, and a single dose protected against the spectrum of RSV disease through 5 and 6 months. So again, very exciting development. And this is, I think, a product that we will look to in the future, and that perhaps can also impact on the price, because if there's more than one product available, that's always a good thing. So WHO recommended for countries deciding to use the long-acting monoclonals, a single dose to all infants born in the RSV season, or at birth where a year-round approach is considered. And if it cannot be given at birth, it could be given at the earliest opportunity, such as an EPI visit for the first immunization. And so did note with concern the limited availability and high cost of nirsevimab, which of course is a major issue in terms of global access and equity. And so this is my last slide. It's from a recent publication. Sorry, I don't have the reference in it in here, but this is the timeline of RSV immunization product availability for Gavi eligible countries, either for maternal vaccine or monoclonal antibodies, where at this point now, where WHO has made a recommendation, I think we can say we're at this point too, where SAPRA has made a recommendation, at least for maternal vaccination. And there are still other steps to go that would lead to rollout in Gavi eligible countries, such as WHO pre-qualification of the products, a multi-dose vial for the maternal vaccine that is being developed, and in the case of monoclonals, product presentation that is suitable. But of course, the biggest issue is pricing and affordability, as well as programmatic issues. So that's where I'm going to end. And I think each country is going to have to decide which intervention, where, what fits with the program, what is most affordable. And I think that's the discussion we're going to have about South Africa now. So thank you very much.
Thanks very much, Heather, for that wonderful presentation, very comprehensive, and I think a really clear slide presentation as to where we are, both with maternal immunization as well as the monoclonal antibody. So Heather, I'll ask you to put on your camera, and so I'll ask the other panelists to also please put on their cameras.
So sorry, did I not have my camera on? Wow.
It's okay.
I'm sorry. You should have told me a long time ago. Talking to a black wall. I'm sorry. I apologize. I am here.
That's okay. Okay, so just to remind everybody about our panel, we've got Heather on our panel, we've got Rudzani, Shabir, Prakash, and Omolemo on our panel this afternoon, and I'm going to go through a series of questions with our panelists. I'll bring various panel members into the conversation, but if you feel that there's something that you want to add to the conversation as a panel member, please feel free to just weigh in. So I think I'll start, Heather, while I have you closing off on that conversation. You mentioned in your presentation that SAPRA has just approved the maternal vaccine. Where are we with Nasivimab, though?
Oh, I think I'm not in the loop with that. I know that Nasivimab has been submitted to SAPRA. I don't know where we are in terms of the process of approval. Rudzani or Shabir may know more. But I know that it was submitted later than the maternal vaccine by the company. So, given that maternal vaccine has just been approved, hopefully it is somewhere in the pipeline, but I'm not privy to that, and others may know more.
Any of the panelists an expected date that we should hear? Shabir, Rudzani, do you know when we should hear back from SAPRA about Nasivimab?
It's expected to be after June, in the third quarter of this year.
Okay, thanks for that, Shabir. So we've got now SAPRA approval of maternal immunization. We've got Nasivimab expected to reach some sort of approval or discussion or feedback from SAPRA in the third quarter of the year. So Rudzani, let me bring you then in. Once we get the SAPRA approval for these products, where does the discussions go? What does NITEC talk about? Give our listeners an idea of what is the next part from a South African point of view.
Thanks, Ziyaad, and thanks for the invitation. I'm trying to move my camera around, to move away from the setting sun here in Cape Town. I think the important thing to note is that, and maybe Shabir will be better placed than me to speak about this, is that in South Africa, we've actually been proactive. We started the discussion long before the vaccine was actually approved, and even before the submission for registration were done, because it was obvious from the preliminary data that this is going to be a game changer. And as a result of that, we actually started a working group, which Shabir chairs for NAGI, to already start thinking about what this will actually mean, and and by the time the final approval, including the time of starting, I mean, I'm sure you're aware now that the vaccine has been, I think, registered now and given approval to start use in the third trimester at 28 weeks by SAPRA. And that aligns with an advisory that NAGI had already given to the Ministry of Health. However, it's just important to note that there's usually a lag between an advisory, even if that advisory is fully accepted by the ministry for implementation. And in part, that is because the introduction of any product, whatever it is, needs to align with budgetary funding cycles. And usually you have to wait for sort of 2 to 3 years unless there's a stash of money found somewhere that is sort of emergency bridging in one form or another. But otherwise, what happens is that a directorate in which that product is being recommended will then go back to the ministry that will then need to table that to the treasury and needs to be budgeted for in the next cycle of budgets going forward. So from where we are right now, I mean, we are hoping that there is enough incentive to do this. As Heather was speaking, I was realizing that whenever you speak about vaccines and the cost effectiveness or cost savings, usually when you give the vaccines, you tend to reap the benefit of that intervention, years in the future. If you give HPV, you only prevent, cervical cancer, maybe, 2 or 3 decades in the future. So the savings are not immediately seen. But as we have seen with rotavirus and RSV, this usually should be enough incentive to take this high on the list of priorities because the benefits are immediately in the next season. So that's basically where we are. And so from the process point of view, all the processes from the point of view of the regulator and advisory have already been put in place. It still puts a lot of pressure on people maybe in this group to take the next role, which is that of advocacy, which means given where you are and the constituency that you bet for, it's going to be important to start pushing that advocacy lever to try encourage those in political positions who can ultimately make this possible. Let me stop.
Thanks so much, Rudzani. And I mean, it's so pleasing to hear that as South African researchers, this process has started even beforehand. And we recognize that this is such an important game changer, as you mentioned. So to put you on the spot then, Rudzani, do you think we're going to have a maternal vaccine rollout anytime this year?
No, I don't believe that will happen this year. And there are many reasons why. Part of it is the budget that I've just mentioned. Secondly, you will need to actually have all your logistics in place. And it's only in extreme cases of emergency where someone would make that feasible, like happened with COVID-19, for example. But at this moment, we're still having vaccines in the EPI program that have been recommended, that we're still waiting to see their full realization. The Tdap that you mentioned in the beginning as one of the vaccines in pregnancy, the phasing out is still taking place right now as we speak, and it's a new vaccine in that schedule. The introduction of rubella, which we have not had in the schedule, and the full implementation of what that would look like. So there are a number of vaccines that are part of the rollout in the pipeline, and I suspect that would be one thing. Secondly, there's all the other things that includes acquiring the vaccine, tendering process, and all the other stuff. So 2025, I don't believe that's going to happen. I mean, Shabir, am I being unreasonable here?
I think the earliest that it will be introduced into the public sector is probably 2020, towards the end of 2026, for the 2027 season, but extremely unlikely anytime before then.
No, thanks for that, Shabir and Rudzani. So Shabir, while I have you answering, you sit on SAGE, and SAGE obviously deliberated quite extensively on both the maternal vaccine and the Sivimab. But really the point of the matter is we want to get this into LMICs where the greatest burden of disease still remains. It is great that high-income countries have adopted this so rapidly. What are some of the discussions at the SAGE level in terms of getting this to Gavi-eligible countries, but also countries that are not Gavi-eligible? Heather did show the timeline, but what are the next processes in terms of what SAGE is looking towards?
Yeah, so SAGE, thanks, Ziyaad. So SAGE obviously makes recommendations which are meant to be global recommendations. They're not directed to any sort of particular income setting. And the global recommendation is, as I pointed out, is that all countries should adopt maternal vaccination or the long-acting monoclonal antibody nirsevimab, without research not showing any sort of preference for the one above the other. I think the reality, we need to be realistic in terms of what will likely transpire in terms of access. So the first issue is around cost. The cost of nirsevimab currently ranges anything between $320 to $550 per dose. And that includes the countries such as Chile, which is a middle-income country. They're not getting it at less than $320 per dose. The RSV maternal vaccine, the cost of that in high-income countries currently is up to $110 per dose. But unlike producers of nirsevimab, with RSV, because it was also supported by Gates Foundation, there's an upfront agreement in terms of price tiering. And we expect the RSV vaccine to become available to Gavi at probably just around $5 per dose. And in South Africa, it hasn't been decided, but I would be surprised if it couldn't be more than $10 to $15 per dose. So obviously, the first case is not going to be able to afford to vaccinate children at $330 per dose. In addition to which, there's also the issue that for AstraZeneca to scale up production would be a massive investment. So even if the monoclonal is registered in South Africa, it doesn't mean it is going to be accessible immediately or widely available because they need to scale up production. It's the number of moving parts. And I think for most low middle income countries in the immediate future, unless nirsevimab comes in at a much lower price, the options are going to be fairly limited to the use of maternal vaccines.
Thanks so much, Shabir. So let me bring you, Omolemo, into this because Pediatric Management Group represents a large contingency of private sector pediatricians in South Africa. And I'm sure this has come to you a number of times already. You know, what are the medical aids going to pay for? You've just heard what Shabir said in terms of costing. Is there an appetite from the private sector, and what is the engagement being in terms of what they would see as a strategy for South Africa?
Thanks a lot, Ziyaad, for the invitation. And so in private practice, the access to funds is not as easy as people think it is. So currently, there are medical aids that obviously allow for use of synergies. And 80% of the medical aids of people in private practice are covered by 3 major medical aids schemes, which is GEMS, Discovery, and MedScheme. And each scheme, each administrator administers various medical aid. So I think that if the biggest thing is going to be the price that AstraZeneca is going to offer for the vaccine. So if the price is more than what they're currently giving the current monoclonal antibody, it's going to be a bit of a problem. If the price is going to be lower, it's going to be better, just based on the price alone. But we obviously, as PMG, once the vaccine once the supply, which is the supply is the most important thing. Once there is supply, then we're going to have serious engagements with schemes to say which strategies is better. So as Shabir said, that nirsevimab will probably be available in the 3rd quarter of the year, which will be obviously out of the RSV season. But looking into next year, the maternal vaccine should actually be one of the best strategies that can be implemented in private practice at the moment. For now, we're stuck with what we have.
So Omolemo, then let me follow that question. So if we fortunate enough to get it at a pricing that Chile has got it, which is $320, or even if we go as far as $550, that's a once-off price for nirsevimab for the season, which is 10,000, between 6 and 10,000 rand. If we look at currently for pelivizumab, it's 6,500 per 100 milligram, which requires 5 to 6 doses per season. currently in private practice, pediatricians order a respiratory panel for 2,500 rand. I mean, I put it into context like that. When you're wasting money on a respiratory panel on an outpatient, then you think, maybe it's not so bad after all.
So I agree with you completely. And PMG obviously has been at the forefront of trying to find cost-effective ways of ordering like respiratory panels, for example. But when you deal with medical aids, you firstly need to come up with obviously good strategy. So I see as this panel sitting down and saying, this would be the recommendation. I mean, at the end of the day, we have to have a recommendation. What will happen is what is best for South Africa. And I think we all agree that obviously maternal vaccination should be the ideal way. And nirsevimab is a once-off dose, but you have to present these things to the medical aid in a way that it's acceptable to them, and subsequently, obviously the price being good, then they will buy it. The problem with medical aids is that each medical aid plan, each patient signs a plan, a medical aid, whatever they are on, and the plan type, and some of the plan types actually don't cover. And one of the big issues with this is that RSV prophylaxis is not a PMB, so they're actually not forced to supply it. But I think it could be spread across all plans if it comes at this reasonable price, and if it's a once-off dose.
Thanks so much, Omolemo. Heather, I see your hand, and Omolemo, I think let's hear from Heather. Heather, what are your thoughts around this?
No, I just wanted to comment on this issue of price. So I want to say, I mean, Cheryl Cohen's group did a cost efficacy analysis in South Africa specifically, and we know that RSV hospitalization costs a lot when you're hospitalized, and it also impacts on families in terms of their economic stability and so on. And it's actually, you know, you think that, wow, the price for a long-acting monoclonal sounds extraordinarily high, but actually what they showed is that a long-acting monoclonal would be cost-effective even at a dose of around $120 a dose. Of course, it's one dose. And that was a conservative estimate because they only estimated protection for 3 months, when we in fact know that protection goes for 6 months. So I just want to say, I think price is a moving target. And I think also, as we saw with HIV drugs, there needs to be greater equity in terms of tiered pricing and those sorts of strategies to make a very effective intervention available. The other thing I want to add is there may be room for both, right? What I didn't show you is the immunogenicity data. And we know that you need about 2 weeks from the time of immunization of a mother to put good transplacental antibody transfer to protect the infants. So mothers who were immunized, babies who were born less than 2 weeks prior to immunization, and those would probably be preterm babies, and also, for example, children entering their second season who are at high risk and probably also for second pregnancies, because we don't know what should be done in the second pregnancy yet. There is a trial starting of immunizing mothers again who've been immunized, but currently we don't know, and the US recommendation is for second pregnancy infants to get a long-acting monoclonal. So I don't think it's an all or nothing strategy. I think there's room for both, and particularly, you know, if we work with sort of public-private, the whole spectrum of where our patients are coming from, I think we should try and get whatever we can for protection.
So what I'm hearing from you, Heather, is that this dual strategy is necessary because there may be instances where maternal vaccination may not be able to provide the effective protection, either because the baby was born prematurely and did not have time to receive antibody, or the mother was vaccinated late. We know a lot of our public sector mothers go in quite late in terms of antenatal care. And there's opportunities where nirsevimab will be useful to prevent disease. Do you think, and Heather, while I got you, do you think there is a role for targeted nirsevimab to high-risk groups then?
I do think there's a role for targeted nirsevimab, as I said, particularly for second pregnancies for infants going into their second season. So yes, I do think there is targeted, and not to forget vaccine hesitancy in pregnant women. I mean, we don't know what kind of coverage we're going to get for this. Traditionally, influenza coverage is so low in South Africa for pregnant women. We saw in COVID a lot of vaccine hesitancy, and the global climate is not exactly pushing vaccination in pregnancy. So we do need to educate and to confirm safety and so on. But I do think there are other considerations for which a long-acting monoclonal there may be a role. And I also think that we've heard from the manufacturers of clesrovimab that they are committed to tiered pricing and to sort of more widespread availability.
That actually is good to hear from clesrovimab. So before I bring you, Prakash, in, we're really talking about the fact that delivery pathways is important. So I think part of this discussion about South Africa is how we're going to deliver this. And when we talk about delivery, colleagues, we're really talking about from production of whether it's nirsevimab or vaccination, the availability of the medication or the preventative strategy. And we've heard about how there may be restriction to the accessibility or one or the other. But then right down into how do we get this into the arm of the mother in terms of maternal vaccination, and how do we get it into the arm of the baby in terms of infant vaccination? Do we use antenatal care platforms for maternal vaccination? Do we use EPI platforms for the infant vaccination? I think these are all important considerations that go into the implementation, as Rudzani was saying right in the beginning. So Prakash, let me bring you in, and I think even bringing the perspective from the EDL committee, if you don't mind adding some of that.
Thanks, Ziyaad, for that question. So on the EML process, I think there are certain principles we follow. And I think we've ticked the box already in 3 of the big ones, which is burden of disease, which we've shown, efficacy and effectiveness, which we've shown, and safety we've shown. The issue obviously is the cost. And it's not just cost, it's the cost effectiveness, budget impact, the issues around willingness to pay, the issues around how we're going to evaluate it. And what it really requires is an HTA, which is Health Technological Assessment. And the EML is undertaking many of these now. So I would ask NETAC to actually start that process to look at the burden. You have costs that are related to the product. And at this stage, we have nothing as a comparator, in terms of what the government is providing, but cost in terms of direct and indirect cost. And you mentioned quite nicely about what the cost is in the community, together with hospitalization cost, together with ICU, lower respiratory tract cost. And those are the health direct cost. But there's also the indirect cost to the parent and the associated things. So obviously, when you get an evaluation of all of that, you will then come up with what Shabir was talking about, is the willingness to pay, or what the country can afford to see how it can undertake this activity, because obviously it's competing with other initiatives. We agree as pediatricians that RSV is the biggest player around for us, and I totally support that. But I think it competes with other pressing needs. And I think we undertake this, we can show that if there's a cost saving at the end of the day, I think cost effectiveness might be easily to do, and cost analysis around that issue will be very useful, but also it will have to look at the budget impact, how much it will impact on the available health money to the government. So I think those issues are very important when we actually going to do this work. And I think we have a good case. I mean, we've got ticked many of the boxes, and we're hearing from Shabir, $5 to $10, I think is affordable. And it's actually in the long run, the vaccine will protect, the future generations as we try, like we did with other conditions. So I think the vaccines have a big place. not to say that the monoclonals don't have a place. And I agree with Heather very clearly that you're going to need both interventions. And I'll tell you why. Because one is vaccine hesitancy, but the other, which is very important, is the practicality of application of these different interventions. Remember, we're giving the vaccine to the mom to try and protect the baby. And we've got data for 180 days. And we know that the highest risk population, we know that the protection is still there, but it's less as you get further down the disease, right? And if you count 6 months, if you get it in let's say 28 or 30 weeks, you're actually counting into the 3rd month of the child. And that would provide protection, but we need to make sure that the duration is long-term to prevent up to 6 months, at least for that 1st year. So I think there might be a need to look at those that missed the vaccine, like Heather spoke about, the use of the monoclonal and the use of the vaccine together, because I think although we say the big group that we actually will be cost saving is in the hospitalizations and the deaths that are occurring in the community, there's a large population of patients who don't die. And the vaccine protection is still around 50% around that group. So I think overall, from the EML point of view, 2 issues. One is the cost and the evaluation of a HTA. And the second is the practicality of use. How can we make this practical? Remember, we have to get mothers vaccinated, and you spoke about the platforms and all of that. But also, as pediatricians, we also have to look at how we can contribute to ensuring that there's a wider cover. So I think there's total agreement that I would support that both interventions are very useful in this situation. That's from the EML process, yeah.
No, that's a wonderful way of putting it in, and I think the 450 people on this call would appreciate that clarity. Rudzani, I did see your hand, and I'd like you to come in here.
Look, maybe I'm not going to say something highly useful, and I'll tell you the reason why. So when you look at vaccines, especially where there's a really meaningful burden of disease for that vaccine targets, it's very, very difficult to find vaccines that are not cost-effective or cost-saving, right? Including the vaccines that we do not have currently in the immunization schedule. They will probably be most likely cost-effective and cost-saving. But as what we know, especially in low and middle-income country context, it's not so much the cost-effectiveness, even for those contexts that determine whether you get a vaccine or not. It is affordability. So, you know, I always give this theoretical example of, in the 1960s, if you bought a Ferrari, as opposed to buying a Fiat, you paid much more for the Ferrari. But if you want to sell that now from 1962, for example, I think it's like others have gone for 50 million, whereas a Ferrari is much cheaper. That's basically what return on investment looks like for vaccines. But the question is whether at that point you can afford a Ferrari or a Fiat. You know down the line you're gonna benefit more from that initial investment in it. And this is basically where we are. And I think that's what Heather has referred to, and I think Shabir was referring to. What will make a big difference is whether the initial cost investment can be offset to make it affordable. It is always going to be cost effective. Even if the price is high, it remains cost effective. It is the question of whether it's affordable today or not. And because at that stage, every purchase is traded off against other priorities, so to say, especially when the economy is under pressure. That's one. Secondly, and this is where we're going to have to figure this out in the public sector in particular. Heather and I have had this discussion before, for example, with long-acting monoclonals. The structure of our healthcare system is that the budgets are taken from health facilities. So if I take the Cape Town situation, for example, the case of RSV accrue to a hospital like Red Cross and Somerset Hospital and Victoria, for example, but the deliveries may be happening at Groote Schuur and Mowbray. The budget for giving those will come from their budget, but the benefits are separate because of the siloed way in which we think about the healthcare system. You'll have to think very, very differently. So the CEO of Groote Schuur must say, I'm happy to give monoclonals when this baby is going out because they will need it, but the reduction in ICU admissions are only down in another facility, and that has happened. It's you know, we've had fights with respect to even giving sort of you know, private-public partnership where you could even claim from medical aid, but the claims, what you pay to treat the patient will come from your internal budget. The accrued returns accrue somewhere else centrally, and so there is that. It's our system. We need to really think differently, and we need to restructure how our healthcare system works, because there's a total accrual of benefit to the system, but the silos may put one burden on one sector or another, and that stops people from actually responding as appropriate because they're not seeing the whole system. That's just what I wanted to point out. Thanks.
No, I think those are such good points, Rudzani. And just to follow on that, Shabir, can I bring you in here? Do you think we have budget? We cut back from PCV 13 to PCV 10, but then we added Tdap, then we changed measles to measles plus rubella. Do we have budget to add this maternal vaccine in? What are your thoughts? Are you optimistic about this?
Yeah, so it's always, I mean, whether we got a budget or not depends on the need. There's always money to be found in the first place somewhere, and as Prakash pointed out, it's also an issue of prioritization. And I think anyone that knows anything about child health will appreciate the impact which RSV has got on healthcare services. And there's a direct as well as the indirect effect, and often we don't actually speak about the indirect effect. And Bangladesh is a good example where they showed that during the RSV season, mortality from other conditions which don't have any seasonality actually increases. And the reason for that is because those other children are largely being deprived of access to health care because those wards are overrun with children with LRTIs. In South Africa, it might be slightly different because we've got greater capacity, but those are sort of the other type of indirect effects we've shown, include things such as the effect of nosocomial-acquired infection during the RSV season, both directly from RSV as well as other AMR bacteria. So RSV clearly is the public health priority, and the question is, can we fund it? And again, it comes down to what the price is. I fully agree there's a role for both of the interventions, and more so in a setting where we're vaccinating between 28 and 56 weeks. We're not going to get 100% penetration of maternal vaccines. Babies that are born to mothers that have not been vaccinated. There's also going to be preterm babies. So babies that are born to mothers that weren't vaccinated simply because they were born before 28 weeks or before 30 weeks. And those children are equally important and extremely important to cover. So we need a combination of the two. So at the end of the day, it depends on the type of advocacy that we engage in terms of convincing the Department of Health of the need. And I think they will be, it's like Heather pointed out, analysis that was done in terms of cost effectiveness, cost efficiency, indicated at $240 per dose. Maternal vaccination was still cost effective. So if it was coming in at $10, $12, it would actually be cost saving, not cost effective. So we're looking at interventions that are likely to be cost saving, depending on its price.
Thanks so much, Shabir. Prakash, can I bring you in? I mean, we've heard that, and before I do that, I'll just ask the panelists. There are questions coming through in the Q&A. If there's some of them that you want to answer, please feel free to go and answer that. We'll take some of these questions just after we've finished this discussion. But Prakash, you know, I'm sure people on this call say, okay, if we're looking at another year or two, another RSV season in 2025, another RSV season in 2026, before we get some sort of solutions on board. We have colleagues from AstraZeneca here, as you know, the Pelavizumab from AstraZeneca and the Sivimab is Sanofi and AstraZeneca together. AstraZeneca has been talking about, you know, we've got Pelavizumab, you know, we can try to reduce the cost of Pelavizumab. And Omolemo, I'm going to bring you in from a private health sector point of view. Prakash, from a EML point of view now, we've got 2 more RSV seasons to protect our babies against. What do you think about Pelavizumab?
Thanks, Ziyaad. I think the answer to that question is, again, you know, we're in a financial fiscal state that we just don't have money at the moment for many things, right? So I think you have to use your money to the best bang you can get out of it. So for me, I think palivizumab definitely is required for mortality conditions, RSV-associated conditions, or conditions that make cost the state a lot of money. Things like chronic lung disease, things like cyanotic congenital heart diseases with hemodynamic stability. And then some of the extreme prems, because, you know, there's a move now to move some of these onto CPAP, and CPAP is widely available across. So like the Americans speak about under 29 weeks, I think if you spend so much of investment in these types of patients and the post-ICU patients, I would strongly recommend that for that group of patients, palivizumab should be strongly considered. And unfortunately, the EML at the moment, it's on a named patient basis. In other words, it's not routinely given to anyone who's got these conditions. So the answer to that from the public sector, if you got these type of patients, I think the answer would be definitely to consider using it, palivizumab, under those conditions. I think it's the best bang for your buck at this point in time. So extreme PREMs, post-ICU, chronic lung diseases, and cyanotic hearts. I think those are the groups that I would, at this moment, because they cost a lot. You remember, these patients end up in the ICU, they get deferred for their surgeries, they die. A lot of them die. So I think we need to just look at it from that point of view. It's not, you know, not that palivizumab doesn't work. It works, we know. It's actually, the evidence is strong and its safety is well proven. But again, the cost is the issue that comes into the equation in this financial circumstances that we are in. Thanks.
So thanks so much, Prakash. Omolemo, from a private sector point of view, are the medical aids paying? Look, we in January already, I think private pediatricians should have started palivizumab if they have access to, from a medical aid point of view. What is the feeling out there? What is happening at the moment?
So I think the problem in private practice, the big medical aids will pay. I mean, Discovery is one of the medical aids that usually pays without a problem. Certain medical aids are very strict, like GEMS. They will only give to less than 29 weeks. Kids were born at less than 21 weeks of gestational age, and they will not give for more. A med scheme similar to what GEMS do usually. So they are getting, I saw a question there that says that 50% of the applications are declined. So if the plan type is not appropriate, and that's an unfortunate thing about private sector, the medical aid is going to decline and say it's not PMD, so they don't have to supply. And secondly, if the patient is more than 32 weeks of gestational age, they're probably going to decline if it's not Discovery. Now, if the company is going to drop the prices, it obviously will be more encouraging. But I think that as soon as the maternal vaccine is available, we should really, in private practice, move into that sector very quickly, together with obstetricians and better obstetrics program, which we have communication with them as PMG. So I think that's going to work better while we're waiting for nirsevimab. With nirsevimab, obviously the price is important. Once the price is available, then it's another round of negotiations with medical aids to see how much coverage and how much they can give. And with these studies coming up, we obviously need to maybe put a document together that will convince the medical aids to actually supply these good preventative strategies for the patients.
Thanks so much, Omolemo. Heather, can I bring you in on the topic of seasonality? So you mentioned in your talk that there may be a role to, or the question of whether we should be providing these interventions in a seasonal way or not. So I think if you can take us through both maternal vaccination as well as nirsevimab, are we looking at year-round, as, for example, some of the countries have done already, or is this a seasonal administration?
Yeah, so I think, I mean, first of all, different parts of the country in South Africa have different RSV seasons, right? So you said you would have started Paddy in Gauteng. We wouldn't have started it yet in the Western Cape, where our season is a bit later. Prakash, I know you have a season that is sort of almost year round, like a tropical climate. So this is the one challenge about a seasonal approach. The second challenge, particularly for a maternal vaccine, is estimating when the infant's going to be born. And I think a seasonal approach for maternal vaccination is really, really very challenging. We also know that the estimation of gestational age in pregnancy is quite fraught. Most of our women do not present early. Most do not have first trimester ultrasounds, which is the most accurate. If anything, they may have a second trimester ultrasound, which has the potential to underestimate gestational age by about 2 weeks. So it's a bit of a minefield in terms of estimating gestational age of vaccination and when the baby's going to be born and covering the baby. I don't think, and then thirdly, for programs, I think seasonal vaccines are so difficult to do, particularly for mothers, and particularly given the different seasonality around South Africa. So I think, and I don't know whether, all the people on the panel who are really expert agree with me, but I think for a maternal vaccine, a seasonal program would be extremely difficult to do. I think we have to have a year-round program that slots into the program, that is done routinely in the sort of 28-week gestational age upwards for mothers. For Nirsevimab, or if Clesrovimab comes along, the long-acting monoclonals, I think that's slightly different, right? Because you're giving it directly to the infant. You know whether the RSV season has begun or not. You have the potential to we give BCG at birth, which is a very well-developed platform. And we could slot it into that program in the seasonal period because, as everyone's highlighted, the potential, a monoclonal is always, I think, going to be more expensive than a maternal vaccine. But if we use a monoclonal seasonally, I think it could be potentially even more cost saving, with all the challenges that go with a seasonal administration of an infant vaccine.
Thanks so much, Heather. So I'm mindful of time and I'm mindful of the number of questions that are coming in, and thanks to the listeners for posting your questions. I want to give a very brief summary and then I'll take some of the questions from the listeners. What we're hearing, colleagues, from this discussion today is that first and foremost, we know the burden of RSV is significant, and the discussions from today is that these preventative strategies, both of them have a role to play in the South African context. The strategy is going to be very dependent on the cost of which it comes in and whether there is budget available. We are hopeful that the vaccine will come in at a lower cost at around $10 to $15, which makes it more affordable to the fiscus. And like Shabir says, if there's drive, we need to get this in, and there will be drive, obviously, from that point of view. The good news, Shabir has also just posted in the chats that in the private sector, the vaccine should be available from late 2025. So we could be getting some sort of vaccination done, Omolemo, in the private sector, and we should be pushing for this. In fact, Omolemo, I think the PMG group and us need to start getting together and going on a whole strategy with obstetricians to get this going into the private sector if it's going to be available at the end of 2025. We're hearing that it's probably going to be available in the state sector in late 2026. But again, the point is that both strategies are necessary for South Africa. Both strategies have value, and we obviously need to think of what that would look like in terms of implementation. The other important point is delivery, and we have to recognize that there's many factors that affect the delivery of both these strategies. Some countries have only adopted a single strategy because they were mindful of these delivery challenges right up front. But those countries may also not yet budgetary constraints to do that. We know vaccine hesitancy is also a reality. And thanks, Heather, for explaining the whole concept of seasonality and whether, and the important points that a vaccine would require a year-round solution, whereas a monoclonal antibody could be more tailored towards closeness to the RSV season and during the RSV season. So I'm going to pause there, Madhi. I'm going to ask if there's any questions from the chats that you think we should take as questions to the panelists. And if there are, if you can just pose them, and if not, we can move on to thanking our panelists.
So thank you to our panelists that's answered so many of the questions already in the Q&A. And I think some of the open questions are more likely duplicates from previous questions. So I think we have addressed most of it. I think, Shrish, maybe we can just address this one question. For the long-acting monoclonals for RSV, there appears to be a significant underrepresentation from other African countries and other low middle income countries. Why are these countries so underrepresented in these trials? And is there any concerns about differences in efficacy and safety? I think that's a very good question that I've been wondering about. And I don't know, Ziyaad, if you can help us with that, or you want to direct it to one of the other panelists.
Yeah, I mean, let's take it to our panelists. Shabir, do you want to come in on this?
I did actually suggest that Shabir would probably be the best person to answer it. I suggested that, I mean, in general terms, I mean, one of the rate limiter in trials is the availability of local infrastructure and personnel to conduct those trials. It's not by chance that South Africa does disproportionately get number of clinical trials for these because of the expertise which is local, where South Africa punches high above its weight in terms of that. You can just see by the people who are sitting here in this panel what kind of work they do, and I think that part of that. And I just suggested that, you know, in other areas there have been differences in terms of our different populations for various reasons, and I don't want to go into that now, where there may be slight differences in terms of vaccine efficacy. I actually suggested to look at, for example, the study that Shabir did with rotavirus, for example, but where there may be slight difference. But by and large, those have never really been meaningfully significant to reach a different conclusion in general terms, but that is possible. But Shabir, you are the right man to answer this question. I'm just the guy from vendor.
Yeah, thanks, Rudzani. So I think you sort of spot on in terms of why there's an underrepresentation from other African countries. Because the requirements to do a study which requires licensure by FDA, the EMAs, are fairly stringent. And the sites need to be able to sort of check all the boxes in terms of ensuring the robustness of data. And unfortunately, that sort of clinical trial capacity hasn't really been developed across the continent. So the companies are usually fairly conservative as to their approach to be involved in the studies. And that's the reason. I guess the question is whether we do expect sort of biological differences when it comes to monoclonals. We probably do expect some biological differences when it comes to maternal vaccination, because there's a number of sort of confounders that can affect transfer central antibody transfer. But when it comes to monoclonal antibodies, biologically, there's very little reason why it's not going to work the same, probably.
Thanks very much, Shabir. Madhi, before I hand over back to you, I just want to really thank the panelists for making their time this afternoon. I think we've had a really robust discussion, and thanks to this very exemplary panel. Rudzani keeps talking about the guy from Vienna. Rudzani, I think you're very important as the guy from Vienna. So like everyone else on this panel, they are leading experts. And I hope as South Africans, we appreciate this, because I'm really in awe at the fact that we've got the leading authorities on this, really sitting on this panel. And thank you very much to all of you for making the time this afternoon, for sharing these insights. I think people from the South African pediatric community are really were eager to hear what is the insights coming from the specialists. And right in the beginning, I think the first answer was from Rudzani to say that we've started the ball rolling before anyone else, before we even got licensure. So I mean, that's just fantastic. It just shows the enthusiasm from the scientists that come from our community in South Africa. So Madhi, I'm going to hand back to you because we got a final message, and just echoing again my many thanks to the panelists for making the time, for Heather for the presentation. Madhi, over to you.
Yes, sorry, before Madhi goes in and you can kill me later, I just want to ask everyone here, the major issue that we didn't talk about is the issue of vaccine hesitancy. For the very first time in an evolving world, we are starting to see the contamination from the global north with respect to how people respond to this. I've got a PhD student who's just finishing looking at even TD in pregnancy, and is seeing vaccine uptake of less than 50%. We're not sure what this lack of confidence looks like. The vaccine will only work if it's rolled out and it's actually taken up. So we're going to have to find ways of communicating. And usually when we do these talks, both for pertussis and pregnancy and RSV, the people who give the vaccines are not you pediatricians, are not us pediatricians. We need to find ways of starting to talk to obstetricians, to midwives, because that is where the program is gonna fail or succeed, not with pediatricians. And that is best, and usually they are the people not in the room when we actually do these talks. We are basically preaching to the converted in many ways. Sorry, Martin.